My dear colleagues, welcome back. Is a very important topic which actually affects all ages of women, be it the adolescent population or the women or the post-menopausal women. When I say this, I say that even the young girls of even 10, 12 at menarche, or even the perimenarchal age group, the reproductive age group, the perimenopausal age group and the menopausal age groups, and therefore I have coined this as a 360 degrees approach, a multidisciplinary approach to understanding PCOS, because it's not only a gynecological domain. So one of the biggest challenges in medicine is that of the polycystic ovary syndrome, because of its complexity, its progression, aspect and the consequences it entails for the woman's lives from adolescence to post-menopause. Now, this particular disease, PCOS as it's called, it changes the women's health paradigm, because if you're starting from the age of menarche, whether it is 10 to 15 years to over 60 years, you see that the myriad of the kind of clinical scenarios we see, from a mere menstrual disorders, hirsutism, contraception, sexual health, infertility, and goes through to the next part of it, which is the reproductive health of the woman, that is pregnancy complications. But of course, as we go beyond that to type 2 diabetes, cardiovascular disease and the longevity of the person. So therefore, we are going through a period of this woman through the pediatric phase, the dermatology, the gynaecology, the endocrinology, and of course the diabetology and the cardiology. Now what have we left? Are you talking about orthopedics? Well, even orthopedics comes into this at a later stage in the woman's life. So therefore, it's a multi-organ involvement. So PCOS is not only about irregular menses, and most of the time children in school are so worried about my child has a PCOS, as if to say that that is a death knell. But let's go and look at this problem in a more analytical way, and then we can talk about the fetal origin of PCOS. I must say here that the genotype or the environment in which the embryos grow also has an impact on the future of the offspring. Little did we know that at the time of the embryo, there is determinants of candidate genes that will tell you that this embryo later on will have PCOS. So what are those prenatal androgen excess situations which will actually tell you that there is a metabolic consequence, which is in terms of the diabetes that we are talking about at later life, and the reproductive consequence, which is the hypothalamic pituitary axis, which acts on the ovary, and therefore testosterone being released, reduced negative feedback of the LH, and therefore can lead to an ovulation. So when you have an adult PCOS phenotype, you can have on the liver as well on the muscle insulin resistance, hyperglycemia. It also works on the pancreas, acute beta cell response, that is the insulin response, a visceral fat increase, increase of free fatty acids, and that leads to a type 2 diabetes. So therefore, my friends, it's not about irregular periods alone, it's not about pimples, it's not about a weight increase. So therefore, there is more to it than just what we are thinking about. So therefore, our encounter with PCOS is the adolescent PCOS, the infertile PCOS and the perimenopausal PCOS. That's how I am going to divide this. So where we look at the adolescent PCOS, these are the children that are found in schools and in colleges. How do we identify them? Do not think that every person who is fat and who has pimples, who has irregular periods, and of course who has a low self-esteem, who doesn't perform well in school, are all PCOS. My dear friends, you can have people who have regular periods, who look very beautiful, who don't have any hair loss, who do not have any hair growth, can also have PCOS. So the myriad of symptoms can be absolutely normal girls to a situation where they are extremely obese, with hirsutism where they actually grow a beard and also a moustache, they become fat, they are very heavy on the buttocks, and they have a pimply skin. Now mothers come with these children across to the clinic that these girls have had their periods, and then for about 6 months they don't have a period. So they are worried what has happened, and as the periods don't occur, these children get very irritable, they are very worried, they think that they are abnormal, and then the mothers keep saying don't worry, everything will be alright. Then month after month they are expecting a period, the only thing that increases is their weight. Finally, when 6 months pass, they come to us and they say, well, for 6 months my daughter has not had a period. And when you do a scan, an abdominal scan, you will find that the ovaries look very polycystic, which means that there are peripheral follicles situated on these ovaries and a very thick capsule. Also, if you look at the blood values of the FSH and LH, there is an elevation of LH, and this is one thing that will lead to an ovulation. When this happens, you will also find that these people are more prone to diabetes, and this is something which also allows for a lot of male hormone predominance, and as a result of that they land up with a lot of hair growth, oily skin and a pimply face. So this becomes a very important issue where a lot of psychological counseling needs to be given, where she has a very low self-esteem, she feels she is ugly. So what are the challenges in management of adolescent PCOS? They are both controversial and challenging. Overlap of normal pubertal changes, under, delayed or overdiagnosis could be the problem. Sometimes at the menarchal stage and within 1 year of starting menarche, there could be delayed periods, there could be irregular periods because the biological clock needs to settle down. So you could give about a year or two for the biological clock to regulate itself, rather than to have a knee-jerk reaction and with the delay of 1 month with the period to come immediately to the doctor. The second thing is inconsistent non-evidence based approaches in the diagnosis and management of PCOS among specialists, general practitioners and allied health professionals, and exacerbated by the lack of robust evidence. For example, only adolescent studies are limited to very suboptimal quality. So you don't take children who come across to a gynecologist and subject them to treatment, because this is a population which is apparently very healthy, that is the 10 to the 19 age group. So we look at this triad of symptoms. One is the hyperandrogenic state, which is the male predominance in terms of the hormones. And what are these hormones? They are the free testosterone, free androgen index, bioavailable testosterone, DHEAS and androstenedione. And what could be the clinical parameters is a severe comedonal acne and hirsutism, and that is something that can be very painful for this girl, and she comes in front of the doctor and very often cries. Very important. So when we look at the adolescent PCOS and how do we manage, a lot of empathy is required. The more important is to treat the mother before you treat the daughter, because the mother is more anxious than the daughter. So when you are trying to look at the PCOS in adolescence, please make sure that the mother is also sitting there, and how is this multidisciplinary approach to be maintained. One, the dietitian needs to talk to her that she has to lose weight, because what the girl would say is, doctor, I do everything but there is no weight loss. This is a common question that I hear from all these young girls. Either they have not continued their exercise, or they've cheated on their exercise, or they have cheated on their diet, because they feel, what is the use, I'm still fat, I'm going to be fat, why should I keep on sort of going on some kind of a cabbage and carrot diet, I might as well eat well. The second thing is, of course, to always have a health psychologist to motivate these children to say, look, If you do this, this is your reward. So the kind of risk and reward kind of approach is very important for these adolescent girls, and they have to be seen at more frequent intervals, not to say you go and reduce 10 kgs and then come back to me. And that's not the way to treat the adolescents. Adolescents need to be pampered, you need to be empathic with them, you should not be regimented with them, and the psychologist will be the best person to deal with them. And the endocrinologist will then look at the hormone profiles and see whether the male predominance of the hormones is there, or is it just an FSH LH altered ratio, or are there any other insulin resistance parameters, and then to decide appropriate treatment for these people. Now, these children are very interested in finding out about those pimples. So you'll have to give them face hygiene, washing their face because it's oily at least 2 to 3 times a day, making sure that they use the deep cleansing milk and an astringent to close the pores. And this is important for them because with this what happens, it makes sure that these skin pores are closed. If it's not closed, then you can have dust getting into them and these comedones can actually erupt. And of course the gynecologist who looks at the periods. Now once these hormone profiles are corrected, then the gynecologist will be able to tell the woman or tell the girl that your periods can be regular. But don't expect the periods to be regular without the tablets, because once you take the tablets, your periods will be regular, but a loss of weight will help you to control and the periods can more or less come back to normal. So if it's like a 28-day cycle you're looking at, maybe even a 45-day cycle would be more nearer normal than maybe once in 90 days. So that should also be possible, but the exercise must continue. What about the PCOS diet? Look at the picture on the left hand side. She is 55 kilos and she looks quite okay, but she was 80 kilos. So an energy deficit of 30% or 500 to 750 kilocalories per day, that is about 1200 to 1500 kilocalories per day, considering that the individual energy requirements, body weight and physical activity levels. So this is going to be the real test for this girl. Practice healthy eating habits, very important. So what kind of exercise interventions in adolescence are we looking at? At least 60 minutes of moderate to vigorous intensity exercise per day, including muscle and bone strengthening exercises 3 times weekly. Minimize sedentary and screen or sitting time and 10,000 steps per day. This should be followed carefully. The other thing is, of course, emotional well-being. Clinical variable, which is psychological, self-esteem, body image, sexual function, all these contribute to the health related quality of life. So when we look at this health quality, what are we actually meaning? Behavioral strategies, SMART goal setting. Now what is SMART goal setting? When we look at SMART, look at SMART, specific, measurable, achievable, realistic and timely. So when I say SMART, do not tell the child go and reduce 10 kilos and come, because she will not come back to you. Start giving small tasks like say 2 kilo weight and that's all I want from you. Just come back in approximately 1 month's time or 2 months time. That's fine. What is measurable? You can measure that 2 kg weight on the weighing machine. What is achievable? 2 kilos is easily achievable and it is realistic and is timely. So the child will say, oh, this is easy, I can easily achieve it. Get her into the routine. Make her feel part of the society. Do not make her feel like an outcast, and that's important. Make sure that she is self-monitoring. The other thing is the stimulus control. Get them into some kind of group activity. Let them all do the exercise together. Then they start comparing. Then problem solving, very important. Assertive training, give them leadership training. Slower eating rather than binge eating. Reinforcement of changes and prevention of relapses. Very important that this cognitive behavioral intervention could be considered. And The pharmacological treatment will be the combined oral contraceptive pill with lifestyle, the pill with metformin, or the pill alone. Now, you must avoid all these pills like desogestrel, gestodone, cyproterone, desoprannone containing OCPs. Now, where does the dermatologist come in? It is particularly where the hirsutism is very obvious. I have seen many girls going into a lot of depression just because they have so much of hair on their face, particularly on the chin, to the extent that they even shave almost every day. Now, shaving is not a very good thing to do because the more you shave, the more hair grows. So, hirsutism becomes a cosmetic emergency. So, oral contraceptive pills could be the first line of treatment, or some anti-androgens like spironolactone or cyproterone. Now, those who are not tolerating the pill, and if alopecia is present, then 6 months of the pill and cosmetic therapy has failed, other forms of treatment can be done like electrolysis and laser hair removal. Now, let's look at the second group of people, that is polycystic ovarian syndrome and infertility. What are the challenges in treating the infertile polycystic ovarian syndrome? Now, we do not have any tools to predict the response to ovarian stimulation. There can be wide varied responses from no response to an over response. Choosing the right drug, dosage and protocol, poor to an exaggerated response, poor egg to follicular ratio, poor oocyte quality, poor fertilization, effect of embryo, prevention of OHSS, fresh versus freeze-all, how to strike that balance, luteal phase defects in PCOS, and effect of endometrial receptivity. These are all the factors that one will have to take into consideration when dealing with a woman with PCOS. So, evidence summarizes and recommendations from the international evidence-based guidelines for the assessment and management of polycystic ovarian assessment and treatment of infertility in IIRRH 2019. The first line of treatment is non-pharmacological management for infertility, and that would be lifestyle interventions like losing weight, psychological treatment, make sure that at least 5% of their body mass is reduced. It tries to get the ovulation or the biological clock in tune. The second will be the first line pharmacological management for infertility, and that could be letrozole, clomiphene citrate with metformin alone, or gonadotropins. The second line pharmacological surgical treatment could be gonadotropins and laparoscopic ovarian surgery, and the third line could be any other appropriate interventions including IVF. So, overcoming these challenges, I can divide it into two parts. One is before I start IVF management, and then during stimulation part. Now, if I have to look at the pre-IVF management, I will have to do a risk assessment, a counseling regarding the risks and benefits, lifestyle modifications before starting IVF like losing weight, making sure if she is diabetic to make sure that the diabetic control is very good, or an oral contraceptives as a pre-treatment, role of metformin in these situations, prediction of risks and counsel them, and of course previous response has to be looked into before you start on this particular cycle. Now, during stimulation, one has to have a tailor-made ovarian stimulation. That means one size does not fit all. Agonist versus antagonist versus mild stimulation again has to be done very personalized. A premature luteinization, one has to accept that this could be something that you have to look for. Overcoming detrimental effects on oocyte quality, iatrogenic versus inherent, and preventing OHSS, coasting in case of an IVM or a GnRH trigger, role of segmentation therapy, fresh transfer, and of course what do we do for the luteal phase. So therefore, we stand at the crossroads, on the one hand to look at insulin resistance, on the other to look at the irisin resistance. Now, what is the irisin? During the past decade, skeletal muscles has also been identified as a secretory organ that releases cytokines and other peptides called myokines. Irisin, an exercise-induced myokine proposed to mediate the beneficial effects of exercise on metabolism. Irisin can induce a change in characteristics of white adipocytes that acquire a brown phenotype. This change includes the activation of uncoupling of protein UCP1, leading to increased respiration and energy expenditure. Brain-derived irisin mediates anxiolytic effects of aerobic exercise and protects the brain from synaptic and memory loss in an animal model of Alzheimer's disease. Hence, the key message would be that circulating irisin in polycystic ovarian syndrome patients seems comparable to healthy controls when controlling for body mass index. Despite this, irisin response in euglycemic hyperinsulinemia in polycystic ovarian syndrome patients appears to be impaired compared with the healthy controls. Now, the next one is the effect of obesity on ART in PCOS. I have told you before that obesity is part and part of the triad of PCOS, and therefore obesity and reproduction as a committee opinion has come out with certain problems, which is what I am going to enumerate now. Difficult imaging due to the adipose tissue, increased gonadotrophin usage, increased duration of stimulation, follicular asynchrony, cycle cancellation, poor response to superovulation, reduced HCG concentration on the day of oocyte pickup, reduced number of cumulus oocyte complexes, reduced M2 oocytes, reduced good quality blastocysts, reduced pregnancy rates, increased miscarriage rates, and effect on endometrial receptivity. The medical management ASRM 2015 suggests that adjuncts to lifestyle for adult women and men with a BMI of more than 30, the orlistat and phentermine are very good drugs to be looking at, and so also the other two drugs of lorcaserin as well as liraglutide. OHS prevention measures and algorithms, very important, because earlier the incidence of ovarian hyperstimulation syndrome was as high as 5 to 10%, but in good centers of IVF now it is less than 1%, and in fact many of the centers today are claiming OHSS free clinics, which is very important. The follicular phase, when you see the AMH which is very high, and if it is above 6, then one must actually prepare that you could have an OHSS response. So one looks at a lower dose of the follicular stimulating hormone when you start stimulating this patient. The antral follicle count and the age of the patient, and in her history if she has had past stimulation which has shown hyperstimulation. The other thing is, when you look at the antral follicle count, if you have more than 18 follicles and or estrogen of more than 5000 picograms per ml, then surely you are landing up with a hyperstimulation syndrome. So if you have got a 5000 to 3500 international units of HCG or a 2500 micrograms of recombinant HCG given, then you must be careful that HCG should not be given in such cases when the estrogen levels are so high. The other thing is to give GnRH agonist, that is 0.2 milligrams of tiptrolin or 0.5 milligrams of buserelin or 1 milligram of leuprolide. When you give HCG, the signs of early OHSS, that is freeze all embryos at 2 pn or day 2 or day 3. Proceed to day 5 and evaluate the patient. Most of the time by day 5 you will know whether she is going in for this hyperstimulation or not, and if she settles down by day 5 you may consider putting in a single blast transfer and vitrify the surplus. If there are signs of OHSS, then freeze all embryos at day 5. Now, when you give a GnRH agonist trigger, supplement the luteal phase with 1500 international units of urinary HCG on the day of oocyte pickup, or the luteal LH of 300 international units on the second day, or an IM progesterone plus estrogen, and then consider a single embryo transfer and vitrify the surplus. The other thing is to freeze all embryos at 2 pn or day 2 or day 3, and the other thing is to freeze half the embryos on day 2 or 3 and culture the rest to day 5 and put all these for freezing or consider a single blast transfer. Evidence of at least moderate quality is metformin treatment before and during an ART cycle for women with PCOS, gonadotrophin releasing hormone antagonist protocol in ART cycles, again moderate evidence, and GnRH agonist trigger and freeze all programs, moderate evidence. The rest of the evidence is of very low quality, which is either clomiphene citrate in ART cycles, cabergoline or progesterone or coasting, and on the basis of this overview, we must conclude that the evidence is currently insufficient to support the widespread practice of embryo cryopreservation. Are we looking at oocyte quality in PCOS, and is it iatrogenic? Is because we are trying to increase the number of oocytes and create a poultry farm, or is it an inherent genetic defect in in the case of polycystic ovarian syndrome? The answer could actually be a plus and minus in both cases, because in a PCOS patient there is always an inherent genetic problem where there are candidate genes that do have an effect on the quality of the oocytes. The second is an iatrogenic effect because of the multiple ovulations that occur, and therefore the quality of the oocytes is compromised because of the quantity. So therefore, with the iatrogenic as well as an inherent quality problem, there will be a lower success rate in a PCOS patient. So let's go to the third category of what are we doing with the post-menopausal PCOS, because today there has been a lot of importance on the reproductive age group in the PCOS patient. Recently we have started looking at the adolescent population, which hitherto has been put as the most healthy part of the girl's life, but now recently there has been a lot of importance to the post-menopausal PCOS women as well. And what is the criteria for post-menopausal PCOS? A past diagnosis of PCOS, and 2, irregular menses, hyperandrogenism, and of course the PCOM. Now, what are the things that we are looking at in these post-menopausal women? Surely we are not looking at fertility. Surely we are not looking at anything else other than diabetes and cardiology. So diabetes is just ahead. Glycemic status is to be assessed in all women with PCOS. What about the oral glucose tolerance test if patients has a BMI of more than 25 kilograms per meter squared in the Caucasians or 23 kilograms per meter squared in the Asian population, because there is a genetic variant in this. So what could be the cardiovascular effects would be, of course, smoking, dyslipidemia, insulin resistance, hypertension, lack of physical activity, obesity, and these are all the predisposing factors for cardiovascular disease, and that is something we should actually consider. Also the ethnicity of these patients. So a minimum of 6 to 12 monthly follow-up, very important. Weight, height and waist circumference measurements must be taken. Screen for other CVD risk factors, and lipid profile to be checked at diagnosis and thereafter depending on the hyperlipidemia. So Annual BP measurements must be taken if it has been normal throughout. So, my dear friends, it's not just diabetes, it's not only cancer, and it's not only cardiovascular disease. This is a new thing on the block. Cancer has actually crept into the polycystic arena as well. There is a 2 to 6-fold increase in cancer in polycystic ovarian syndrome. Why maybe it's so? Well, I must tell you that there is an increased estrogen production. With increased estrogen production, there is a hyperplasia in the uterus. As a result of hyperplasia, the endometrium becomes very thick, and because the endometrium doesn't shed, you will find periods of amenorrhea which could be as much as 6 to 8 months, and sometimes women think that they've gone into menopause, but actually they are not into menopause, they are still perimenopausal, and the endometrial thickness in these women can be as thick as even 18 millimeters, which is not expected in that age group. Now, once you see such a thick endometrium and then it starts bleeding, there is quite a lot of bleeding and can go on for as much as 15 to even 20 days and continue to bleed, and when it stops for a day or two, it starts once again. And this is something that one has to keep in mind, that when you see this kind of endometrial hyperplasia, you always have to keep cancer in your mind. So, when there is a thick endometrium like this, rather than to just go and give them some kind of medical curettage in terms of hormonal therapy and then get them to have withdrawal bleeding, it's important to do a biopsy and make sure that you've ruled out cancer before you think of any other treatment in this particular case. So, imagine 2 to 6-fold increase in the risk of cancer. So, persistently thickened endometrium should get your antenna up and make sure that you check the endometrium for cancer. And of course, prolonged amenorrhea, abnormal vaginal bleeding, excess weight all come under that category for endometrial cancer. So, please keep in mind, transvaginal scan and or endometrial biopsy is a must in these cases. Imagine these women who have PCOS, even though they appear very chirpy, they appear light-hearted, and this particular woman says, I am so classy that even my ovaries are wearing a string of pearls. What she is referring to is all those follicles that are situated at the periphery of the ovary. But my dear friends, PCOS is not all that classy. PCOS can be miserable. It can lead to a lot of problems, both psychological and physical. So therefore, the more we learn about it, we may have the next patient on which we have to start all over again, and we may not have the answers there. So, we need to have a multidisciplinary team for this. No longer is PCOS only in the hands of a gynecologist. We need to have a plan, a lifestyle plan and support, treatment of hyperandrogenic symptoms, endometrial protection, contraception, fertility counseling, psychological and behavior support, metabolic screening and intervention, nutritional counseling, all this put together with a lot of empathy. These people need our support. We can control it, but whether we can cure it, the answer, my friends, is no. We can control it, we can make their life much better, and their quality of life also can be much better. So, my dear friends, we have not reached the end of the tunnel. The more we learn, the more we need to know. We always have patients with a lot of complex problems. It cannot be very simple. So, where is the end? And the research must go on. And stay strong, keep fighting, and we will win this together. PCOS is a multifactorial problem, and we will keep researching and we will get more and more. Until then, stay with us. I'm very happy to be with you, and thank you for listening.